Okay, well, while Judy's pulling up her slides, I will go ahead and introduce her. Hopefully at this point, I think all of you should have met her either in person or virtually between either our ICC or EOA courses. But for some of you, that was a long time ago. So I wanted to take a moment to introduce our wonderful speaker, Dr. Judith Paice. She will be speaking on balancing pain management during the time of an opioid epidemic and a pandemic. So Dr. Judith Paice is the director of the Cancer Pain Program in the Division of Hematology Oncology, and she is a research professor of medicine at Northwestern University in the Feinberg School of Medicine in Chicago. She is presently a member of the NIH HEAL Initiative Multidisciplinary Working Group and has served as president of the American Pain Society and secretary of the International Association for the Study of Pain. And something that is a fun fact, which I should have known, but I just figured out recently, is that Judy was actually one of the original consultants for LNEC. So she has been along with us for this entire time. And before I hand over the mic, I just wanted to remind everyone to please make sure to mute themselves. That hopefully you should be able to do on your own. We made sure to set that setting, but if not, I will mute you on my behalf. But thank you so much, Judy. And without further ado, we'll go ahead and get started.
Thank you, Haley. And thanks everybody for taking the time. I realize how difficult this is to set some time aside. I also realize that we are a diverse group. Some of you may be actually administering opioids or other medicines. Some of you may be prescribing them, and some of you may not be involved in those tasks at all. And so I want to be sure that you all understand and realize that it really is a group effort, and each of you plays a role in all of these issues that we're going to be talking about today. And I'll try to make that eminently clear throughout. So you may have heard me talk about this before. We've got these unintended consequences. Pain, unrelieved pain in particular, and especially unrelieved pain associated with serious illness, is a public health crisis. And I have to say, it has gotten worse rather than better, often because of the unintended consequences of efforts derived to combat the opioid misuse and overdose deaths that are occurring. That's another pandemic, if you will, or public health crisis. You all probably heard that last year, from April 2020 to April 2021, there were more than 100,000 deaths associated with drug overdoses. That's much higher than years before. And about 75% of those involved an opioid, not necessarily only an opioid, but involved an opioid. So I propose, and many others have as well, that the unintended consequences of efforts to reduce the opioid overdoses have created stigma and have created unrelieved pain through a variety of efforts. And I'll describe them as we go along. It was simple solutions that helped create this current crisis. And what I mean by that is we weren't getting physical therapy paid for. Most of the multidisciplinary pain programs around the country that are real multidisciplinary pain programs, where you have physical therapists and occupational therapists and psychologists and social workers and others, most of those programs have closed because they simply cannot be financially viable given our current system of reimbursement. So what did we have left? We couldn't get mental health counseling, we couldn't get physical therapy. And so what did people do? They turned to writing prescriptions, maybe more than we should have in retrospect. So it's going to take comprehensive, complex solutions to resolve these public health crises. And now we have this other crisis called COVID-19, which we know has exacerbated our substance use disorder challenges, and it through in part isolation and vulnerabilities and enormous amount of loss, grief, and bereavement. So all of this takes a team, and I started to make this point, and I really want to be sure everybody feels confident that you have a role in managing all three of these epidemics. So Some of you, in fact, most of us, are going to come from healthcare settings where there isn't necessarily a team to manage pain control. Some of you come from palliative care teams. Beautiful. Others of you are coming from oncology programs or others where maybe you don't have palliative care available to you. I can tell you that in my outpatient program, our palliative care team is superb, but right now it's about an 8-week wait to get a consult for palliative care. So those are real significant challenges. So what have we had to do as a result? We have to build our own team. And maybe it's kind of a matrix team. It's knowing who your referral resources are. I consult my social workers all the time. I consult our psychologists all the time. I ask the chaplains to come and see our cancer patients. In fact, we are working on having a dedicated chaplain in our outpatient oncology clinics. We already have one for our inpatient settings. So how do we pull together people who have skills that can address pain management, mental health challenges, substance use disorder, loss, grief, and bereavement associated with COVID and other variables that are really affecting most of our population today. So if you don't have a team, build one. So to reiterate the obvious, the good news is, especially for those of you working in oncology, and forgive me for those of you who don't, that is my background, so I'm going to tend to draw upon those experiences. But the truth is, not just for oncology, but for cardiology and neurology and solid organ transplant and other centers within institutions, we have more treatments. And many of those treatments are leading to much improved survival rates. And unfortunately, many of those are leading to persistent pain syndromes. The more bad news is what we've talked about, the opioid abuse epidemic or opioid overdose epidemic, and now COVID-19. I love sharing this graph, and I'd like to see it updated a bit. But what it highlights for me is that, yes, in the beginning, this first wave of opioid overdose deaths was likely related to prescription opioids, at least in part, not solely, but at least in part. And then people began to notice that there was this problem. And so efforts were made. There was a reformulation of some of our long-acting opioids, like OxyContin, for example. There were more efforts derived to ensure that prescribing was safe. We saw the advancement of prescription drug monitoring programs around the country. And right now, essentially 49 out of 50 states have a well-functioning prescription drug monitoring program. And I can look at that software package and see if my patients have gotten opioids from other practitioners. And even I can access data from other states as well. We also started to see some of the negative side, which was insurance companies really putting limits on how much opioid could be prescribed. And so the percent of people developing overdose associated with prescription opioids started to decline, and we started to see a very significant increase in the amount of synthetic opioids that were contributing to these deaths. And that is where we are at today. Illicit fentanyl is truly the match that's lighting this horrible fire. In addition, now we've got some additional problems, and that is we are starting to see methamphetamine. And why do I say that that's a problem? Methamphetamine, we've seen it for a long time, but it is now pervasive throughout the country. For a while, it was more confined to rural areas. Now it's all over. And the challenge is that when people misuse amphetamine-like drugs or methamphetamine, we see a significant amount of cardiac related damage and deaths. And we do not have a reversal agent like naloxone, as we do for opioids. And we don't have medication assisted therapy. In other words, an agent that would be safer to replace the methamphetamine. So it's truly a very difficult wrinkle in our substance use death related numbers. Now, a while back already, the CDC came out with guidelines related to opioid prescribing. And there were many of us in the oncology world, in the palliative care world, who were protesting aspects of these guidelines. Initially, they did not exclude people with cancer, for example, or people with palliative care. It only excluded people who were in hospice. The other concerns we had was that these were pretty prescriptive about how many days of prescriptions should be provided for patients. So like a 3-day supply or a 7-day supply in certain circumstances. And the authors also limited the amount of opioid that should be prescribed. Now, these were supposed to be voluntary guidelines, but we quickly saw that they were adopted dramatically by the insurance companies. So this was a patient I cared for who had metastatic prostate cancer. And you can see that big red arrow points to a spinal cord compression, an impending cord compression. So he still had pretty significant pain from this bony metastasis. He was admitted to the hospital, got some radiotherapy and some other treatments. And when he was discharged, he went home on opioid therapy. We had great difficulty finding opioids at retail pharmacies. And this was a gentleman of color, particularly neighborhoods and areas that serve people of color, serve people with low socioeconomic status and other variables. We have great difficulty getting opioids or other controlled substances. And frankly, it's really a problem that transcends a neighborhood now. We also saw that as this poor man finally did find a pharmacy that was nearby after his family had taken him to several, the insurance refused to pay for the supply of medications, saying that the dose exceeds the CDC guidelines and the number of tablets exceeded the 7-day supply from the CDC. So what happened for this gentleman is something that I'm seeing now happen for many of my patients, and that is they're reluctant to take the medicine. They're afraid that they're going to run out because they've run into so many challenges accessing the medicine. And they feel so stigmatized. Look at the way that pharmacist treated me. I'm really worried. I feel like, Judy, you keep telling me that you're not seeing risk factors and that I'm not going to develop problems with substance use disorder, that we're going to work hard. And yet everything I'm seeing on the outside is reinforcing that these are addicting and that I'm going to become an addict. So thankfully, the CDC guidelines have been updated. Right now, they have not been released. They are open for comment. So all you have to do is Google CDC Clinical Practice Guideline for Opioids 2022, and you can easily access. It's part of the Federal Registry. And so you can obtain a copy of these guidelines. And I will tell you, the good news is that they no longer emphasize the limits on days of prescription or dosages. So at about that same time, the American Society of Clinical Oncology asked a group of us to put together a clinical practice guideline that would assist oncologists, advanced practice providers, and other providers working in the oncology field to understand how we might best provide pain management for our cancer survivors. Now, the first challenge that we faced was defining cancer survivor, because most of the cancer support services or support groups define it as anyone from the time of diagnosis, which is inclusive, but not precisely useful or helpful as we're trying to understand when should we prescribe opioids for people, when is it not so safe to prescribe these medications, as well as other treatments for long-term chronic pain syndromes or persistent pain. So if you look at the data, we have more than 16 million people in the United States who are considered cancer survivors. 2/3 of them are living 5 years or longer. And unfortunately, studies that have been conducted, and actually there's one that was conducted more than 10 years ago, and the same investigators repeated it and found the same finding, that 40% approximately of cancer survivors experience significant pain. I really like this article by Debbie Mayer. It was published in 2017 in Lancet Oncology. She really articulates the different categories, if you will, where cancer survivorship may occur. We aren't one or homogeneous group. There are some who are going to live cancer-free for the rest of their lives. Others are going to live many years, but may develop a late complication. Others may live many years, but develop a late recurrence, and others may live many years and then develop a second cancer. And I've seen all of this in the patients that I've cared for. Patients who were treated for Hodgkin's lymphoma, who were given the old mantle X-ray treatment, and now they've developed a sarcoma in the treatment field. I've had a couple breast cancer patients who have developed sarcomas and secondary malignancies in the treatment field. So these are real events that occur. Are they cancer survivors or not? And then what about those people like our myeloma patients who are living now, instead of 1 year or 2 years, they're living 5 years, 10 years, 15 years. We have several patients in our practice, and it's a very robust myeloma program. We have several patients who are approaching 20 years, but they're still getting treatment. Are they a survivor or not? So those are some of the things that we kind of contended with, and we decided that our definition would include people who were no longer in active treatment. So these were the key recommendations: screening and assessment, and we made a strong effort to educate oncology providers and others about the different pain syndromes that we see in oncology. The second aspect of key recommendations was about treatment, and then the third was risk mitigation. So a little bit about the syndromes that you'll see. We see the chemotherapy associated syndromes, things like chemo-induced peripheral neuropathy or steroid-induced avascular necrosis, hormone-mediated pain syndromes like arthralgias and myalgias associated with the aromatase inhibitors. We see radiation-related pain syndromes, although I do have to say this is a real positive. As a person who's worked in this field for many decades, I am seeing fewer and fewer chronic pain syndromes associated with radiotherapy. In the past, I saw quite a few fistula formations, enterocolitis, lymphadenopathy. With the advent of just very highly targeted radiotherapy, we're seeing less and less damage to the healthy tissues. Stem cell transplant, as this program evolves and now includes CAR T therapies, we are seeing graft versus host disease, which can affect any organ system in the body and can include many painful kinds of phenomenon. We see surgical pain syndromes. These are the ones that we've known about for a very long period of time. Post-thoracotomy syndrome, post-mastectomy syndrome, lymphedema, phantom limb sensation, etc. And now, as we are using more and more immunotherapies and other targeted therapies, we are starting to see things like peripheral neuropathy and other pain syndromes that we need to be constantly aware of and consider as we treat more and more patients who survive these newer therapies. And we have to keep our eye on some of the evolving therapies. So that was the first area of recommendation: how to assess and what are you looking for. The second was, how do you treat it? And we really wanted to emphasize to our oncology colleagues that optimally we use multimodal therapy. And here's again where this takes a team. So some of you who come from our social work background or psychology background or chaplain background may be very adept at some of the psychological approaches like cognitive behavioral therapy, distraction, mindfulness, relaxation, guided imagery, even prayer. Some of you may be very adept at some of the integrative therapies, like things like mindfulness, which can fall under both categories. We certainly call upon our integrative therapy colleagues to administer things like acupuncture and massage. Music therapy, optimally conducted by a therapist who's licensed in that area. But at times we don't have those individuals. And so we draw upon the patient's love of music, and we use that as a way to reflect. Physical medicine and rehab, that's PT, OT. We can also think about referring patients to some of the support groups that offer things like chair yoga or stretching exercises or aqua therapy. All of these kind of took a hit during COVID, as we'll come to later, but are starting to open up, and some have become very adept and have begun using virtual approaches so that our patients who are able to use technology can do their chair yoga at home, for example. Kind of hard to do aqua therapy at home unless you really have, I guess, unless you live in the Los Angeles area where you have your own pool. Doesn't happen here in Chicago very often. So interventional therapies is where we would call our anesthesia colleagues or interventional radiology colleagues. Again, you build your team. So it may be a matrix. It's highly unusual that these folks would actually be in the clinic with you, but you know who to call. That's where building the team is so important. And then neurostimulatory techniques. Again, these are from some of our interventional colleagues, but even things like TENS units can be purchased on Amazon for less than $50 in many cases. So not only can you all be involved in providing some of these therapies for patients, but we rely upon our social work colleagues, our chaplain colleagues to help us during the assessment phase to understand who may be experiencing more suffering, or maybe the suffering role is impacting the pain report, who might be a good candidate for some of these psychological therapies or integrative therapies or other kinds of therapies. So never hesitate to understand your role in recommending some of these kinds of approaches and conducting the assessment. Now, we also wanted our oncology colleagues to be aware of the adverse effects of long-term opioids. Many of us learned about opioid use many years ago, where really the only people who got opioids were people who were at the very end of life, often actively dying. And it may not be safe and effective to extrapolate those experiences to that person who now has a lifespan of 20 years or 30 years or more, because there are these long-term adverse effects that we didn't know about before. Again, because we only gave opioids to people who were actively dying. So we learned that opioids do affect the hormonal system, particularly causing hypogonadism, which then can lead to infertility and fatigue and likely problems with osteoporosis and osteopenia, a problem that many of our cancer patients already are at risk for. Sexual issues like reduced libido and reduced function. So I use this in my teaching with patients all the time to let them know, even for that patient who maybe has severe mucositis and we're giving them an opioid, I'll let them realize that as soon as we wean off that opioid, libido and function return. We know that there are neurotoxic effects of long-term opioid use, long-term effects on the GI system, and then of course disordered breathing and obstructive sleep apnea, all things that we're very concerned about and from a safety perspective. So that led us to describe the risk assessment that needs to be done. And again, for those of you who are not nurses or not physicians, you have a role in this too. Looking at things like past or current use of substances. Patients may open up to you in ways that they may not to the person who may be prescribing controlled substances. So if you learn through your assessments about some of these past or current usage of substances, it's really helpful to help the team understand. Also, these later questions about abuse and PTSD and physical and emotional abuse that patients may have had may come up during some of your assessments. You as a group, the social workers and chaplains as a group, you've been on the forefront of asking patients about these kinds of past experiences. And so share your techniques and share your wisdom with all of us on the team. So After we conduct a thorough assessment, we kind of have to categorize patients' risk, and we use different precautions to make sure that patients remain safe. And we do this for everybody, whether they have low risk, moderate risk, or high risk. The intensity of these interventions may be escalated with patients who have much higher risk. So we use those prescription drug monitoring programs, particularly for those of you who might be prescribers. We will get urine toxicology. I just found a patient who went to the emergency room yesterday at another hospital closer to her home with severe abdominal distress and nausea and vomiting, and they took a urine toxicology and they found that she was positive for THC. And through some careful interviewing, it seems that she does use THC fairly frequently, and that yes, the nausea that she has that seems to be recurrent, and this is a cancer survivor, she's not in any active treatment at this point, seems to be associated with cannabis use. And we know that there is a hyperemesis syndrome that has been observed in people who use cannabis. And one of the kind of red flags that helps you to understand that it might be related to the cannabis is that the patient will tell you they take a warm shower or a hot bath, and that seems to diminish the nausea and vomiting. So unfortunately, she also was positive for cocaine. So she and I are going to need to have an important conversation in the next couple of days. Some people feel strongly about the benefits of agreements and contracts. I actually chafe a bit under these written kinds of versions. I do verbally explain to patients what is expected on their end and my end, but I feel somewhat uncomfortable, and everyone has their own mindset. And I've talked to colleagues who I respect deeply, and they believe in the efficacy of these written types of agreements. So how do you put all this together? Your risk assessment, your pain assessment, and then your knowledge of their, prescriptions and how many opioids they've gotten, what's been dispensed, their urine toxicology results. So how do you put this all together? Well, first you stratify the risk, as I've mentioned. Is this a person with low risk, or is this a person with really significant risk of substance misuse? And you have to decide whether or not to prescribe. And that decision is a little bit easier if you find an etiology of the pain that really doesn't respond to opioids, or it's not sufficiently intense. Remember, we should only use opioids if the pain is moderate to severe. And certain pain syndromes like peripheral neuropathy really are not, that's not the primary category of drugs that we use to treat peripheral neuropathy. We tend to use some of the adjuvant analgesics or other agents. So you have to decide whether or not the etiology of the pain makes sense to prescribe opioids and whether it's safe. And then if you do prescribe opioids, you need to minimize the risk. And that occurs through optimizing some of the non-opioid drugs if you can. So the adjuvant analgesics, the non-opioids, using multimodal pain therapy, calling in the physical therapist, the integrative the health therapist, the interventional therapist, and all the others. And then monitor behaviors. Do you see some behaviors that are of concern? Early refills, requests for increases in the drug rather than stable use of the medication. Lost medications is another one. All of those are very challenging and concerning kinds of behaviors, and you have to respond to them. So for some people, it may be that you have to start weaning them off the agent. It's just not safe. I had a patient recently who she was taking pretty significant doses of alprazolam and came to us from another hospital and took all of her drug and in a very short number of days and ended up having a seizure. And thankfully, she had a family member at home who witnessed this seizure and took her to, or called 911, and she was taken to another local hospital, but it was benzodiazepine withdrawal. So we really need to address the people who have substance use disorder so that they can be safe. Now, it's really easy to say in this table, consult psychiatric and/or addiction specialists, but I don't know about you. Trying to get an appointment with a psychiatrist nowadays is really, really challenging. In my institution, this same female patient got an appointment for October. So that's not going to help us right now. She does not believe that she has any problem with addiction, so refuses to go into addiction program. That's another issue. We also have huge issues getting into addiction programs. Many of them will not take people with Medicare or Medicaid. And unfortunately, many people who have had problems with addiction are less likely to have commercial insurance. I want to share with you this resource because I find it very, very helpful. About a third of the patients I care for do have some sort of substance use disorder history, present or current. And so the Substance Abuse and Mental Health Services Administration, or SAMHSA, run by the government, has this great website. And if you can see the banner right at the top, Find Treatment, and you can plug in the patient's zip code. You can also determine whether they have commercial insurance or Medicaid, and it will automatically plug in for you all of the available programs within a certain range. So you can say 25 miles or 50 miles. And some of these programs now, because of COVID, are offering virtual kinds of therapy sessions. So it's a great resource. Now, what happens when you either no longer need opioids for that patient, or the patient has aberrant behaviors and you need to wean? You can safely reduce the opioid dose by about 10% per week if the patient has been on an opioid for a very long period of time. And I mean by like a year or longer. I tend to go 10% per month, particularly if this is an outpatient who is not experiencing severe adverse effects. Maybe they just no longer need the opioid. This way, I tend to get better buy-in from the patient, and we tend to get better results if we go a little bit slower. But there are times when we need to go much more rapidly when there has been significant aberrant behavior. We offer psychosocial support, as hard as that is. And again, this is where our social workers can help. For some patients, our chaplains can help. We optimize the non-opioid and adjuvant analgesics. We use antidepressants. We do not add more benzodiazepines. That's another very unsafe group of drugs. And again, coming from an oncology perspective, I need to tell you, so many of our patients have been given benzodiazepines, particularly lorazepam, in some sort of effort to treat nausea. And once the patient is even done with their chemotherapy 6 months later, they're still on the lorazepam. So it's not an optimal drug for treating anxiety or uncertainty. And many of our cancer survivors indeed have great uncertainty about their future. There's great fear about whether this cancer will return. You often hear patients refer to the sword of Damocles, it's hanging over their head and they never know when it's going to fall, whenever they're going to get that second bit of bad news. And I always give people a written plan, a roadmap, so they know what to expect. Now, what about safe use? I spend a lot of time teaching patients about this. And again, this is where our social workers can help and others. Educate families and patients that these substances need to be locked up. You don't leave them out on the kitchen counter. You don't leave them in the medicine cabinet. Optimally, you have locked boxes, and we now are giving nasal naloxone, particularly if anyone has a dose greater than 50 milligrams of morphine equivalents per day. That's sort of one of the guidelines, although there's no real science to that. However, if anybody has grandchildren that come to visit or children in the home, teenagers in the home, I will give them nasal naloxone. In the vast majority of cases, insurance is paying for this. And just to give you an example, about a year or so ago, one of our fellows was on the local train system here in Chicago, and a patient OD'd. a person OD'd and nobody had nasal naloxone, including the conductors or the staff on the train. And so all they could do was kind of shake the patient to try to get some respiratory stimulation until the next station, and then 911 could meet them, and 911 had nasal naloxone. And then we do advocate for safe disposal. Many of our 24-hour pharmacies are offering little kiosks where people can, no questions asked, just return the medications. If that's not available for individuals, many police departments, courthouses, and other community buildings are offering either kiosks or other opportunities for take back. And then the DEA runs a program twice a year called National Take Back Day. The next one is at the end of April. It's usually a Saturday, usually the last Saturday of the month in April, and then in October. And there's a little bit more wider availability of these take back programs. Again, no questions asked. So I've just shared with you some of the challenges we've faced in providing opioids, providing pain management for people who are survivors, and really for all of our patients with serious illness, whether it's cancer or other serious diagnoses. And much of this has become extraordinarily complicated by the opioid epidemic, which has become complicated and exacerbated by our COVID-19 pandemic. Now, how has that happened? I mentioned previously that the isolation, the distancing that we've all had to employ over these last 2 years has been hard for all of us. And it is especially difficult for anyone who is at risk for substance use disorder. You have all heard in the lay press how the intake of alcohol has exploded. In fact, I found it kind of funny that all of our liquor stores here in Chicago were considered essential businesses when we first went into lockdown 2 years ago. And I guess it makes sense so that people had some kind of support, but also to prevent withdrawal from alcohol for those individuals who do use or misuse. Additionally, many people in the world around us have lost loved ones and have lost jobs. They have lost their income, their way of living. Some have lost their homes, and all of that has led to extraordinary grief. And unfortunately, this has led some who may be at risk for substance use disorder to now develop aberrant behaviors. And then finally, those people who have substance use disorder, whether they were sober or not, have found their sobriety deeply affected, again, by the pandemic. The kinds of programs that people use to offer support, like Alcohol Anonymous, Narcotics Anonymous, and others, all went to virtual for a long period of time. One of the key aspects of these support sessions is community. And you all know how hard it is, as evidenced by today, how hard it is to build community virtually. So we saw many people who had been sober for a while compromise their sobriety through the COVID-19 pandemic. And others who had risk factors start to use substances. Now, what do we know about COVID? It produces symptoms that are painful, that all of us have expertise in managing. This was one of the early papers that came out in 2020, documenting patients who had been seen by a palliative care program in the United Kingdom. And what these individuals, these researchers found is that of these patients who tended to be older, 82 was the mean age. These individuals had a poor Karnofsky status, so they were frequently people who were more frail. These folks were in the hospital for a mean of 4 days, averaging from 1 to 12 days. The most common symptoms were shortness of breath or breathlessness, agitation, delirium, drowsiness, pain. And so in the United Kingdom, there tends to be a greater use of subcutaneous infusions. So of these patients, there were 101 patients, 58 of them were put on a subcutaneous infusion of an opioid. So you can see quite a significant percentage of these patients, 67 out of 101, so close to 67%, 2/3 had shortness of breath, 40+% had agitation. Very, very common prevalence. I really thought this was a great paper, came out of Canada, because it enfolded palliative care principles with this COVID-19 pandemic. And they provided some very practical kinds of recommendations, like you need to stockpile medications, those of us working in the palliative care arena, including symptom management kits, for both for long-term care settings and community settings. We needed to work with our legislator to suspend some of the regulations that made it hard to prescribe opioids and access opioids. In the United States, they did that by loosening up some of the telehealth so that we could actually prescribe opioids on the basis of a telehealth visit, which was not allowed prior to the pandemic and the changing in those regulations. They also talk about what staff should do. Things like get all the staff who have palliative care experience, mobilize them and use them within healthcare settings, because those are the people, you are the people who have the expertise in symptom management. And to use the palliative care experts to educate frontline providers to be able to provide better symptom control. And then use our allied health folks, like our social workers and our chaplains, to provide emotional support, not only to patients, but also to the family members who were really struggling because they couldn't be with their loved ones, and to provide grief, loss, bereavement kinds of services, not only to family members, but to staff. And I suspect that many of you have been involved in many of these kinds of activities. I wanted to just alert you in the final moments of our presentation here about the resources that are available on the LNEC website. So all you have to do is Google LNEC and you'll get the American Association of Colleges of Nursing page that has all the LNEC tools available. You can learn all about the curricula, the team, the courses. And if you see at the top here in green, LNEC support for nurses during COVID-19. And quite honestly, our non-nursing colleagues would find these helpful. We developed infographics. They are one-page tools that can help provide education. You can just put them up in the conference rooms. You can share them with individuals, including things like the care of people with pain related to COVID, dyspnea related to COVID, and then cough, delirium, and anxiety, whether you have COVID or you're fearful of developing COVID, which is pretty strong emotion. We decided just recently to also develop infographics that were not related to COVID, but that could help all of our LNIC participants, again, in educating others and as quick tools to manage some of the more common symptoms. So we look to do pain, dyspnea, and anxiety as some of the most common symptoms that we see in palliative care. And we put together a single page of meditation and mindfulness apps for nurses and for patients and for all of you who help teach patients about mindfulness or breathing exercises. We really went through and checked many of these apps are free. you can get expanded versions of them and pay a little bit more each month. These are apps that are not connected with commercial enterprises where they're going to try to sell you yoga clothes and things like that, which is what we found as we were surveying many of the apps. So you can access this, and as you access this as a PDF, you can link directly to the websites for most of these programs, and then these can also be obtained through your app store. So that was a very quick overview of opioid epidemic, pandemic of COVID, and then how we can use our tools, our team, to manage pain effectively. So I'm going to stop sharing there. And I see, let's see, are there anything? Brian shares that the liquor stores were closed in Pennsylvania for 2 weeks, and then they became essential as well. I suspect there was maybe some conflict about that. So, and then the idea of sudden alcohol withdrawal gives another perspective on the liquor stores. Gun stores were considered essential in your state, Mary Arnold. Thank you for sharing that. Chicago is supposed to be a gun-free zone. For anybody who reads the news, you probably know it is not, but you're not supposed to sell them in Chicago. So we didn't have gun stores selling them. So questions, comments, anything people would like to discuss. You all have expertise in this area.
Are we allowed to talk out loud?
You bet.
Whoa.
Love it.
Hi, I'm Mary with the gun stores in New York. Yeah, there were long lines out. The one that was the one that was on my hospice home care route all the time. This was a great presentation. I just want to thank you for it. And wow, so much to think about. I work in hospice, and in hospice, I don't have to worry about, like, I just say more morphine and it happens. And so I don't quite know the reality of the rest of the world and what everybody else is working with. Except my voice teacher had a wound, and she was doled out 8 tablets, and she was terrified of using them and not having them when she needed them. And that was an eye opener for me, because I said, in hospice, we don't have to let anyone suffer, thankfully.
Yeah. And yet, Mary, you still do have to be cautious about safe storage. I know you facilitate the safe disposal, but even though you're in the home frequently, teaching family members, about keeping it safe, I'm sure is part of your educational role.
Yes, it should be. I think I maybe not as often. It may be a little more lax than would be good. And then we learn pretty quickly what homes, because we are, checking the meds every time we go in there, and in part to see that they're used properly, and in part to see, do we have the people on appropriate doses. It turns up pretty quickly whenever there is a problem, and we do have locked boxes. And I've had people who, when you said your patient took all of her alprazolam all at once, I've had patients like that where I literally had to have our pharmacy deliver 1 day worth of medication every day, because otherwise it would all be gone instantly. But, luckily we also have a great pharmacy contract that allows that to happen.
Wonderful. That's really good to hear. Thank you for sharing all of that, Mary. Anyone else have something they'd like to share or questions?
Would this session be available when the recording is available for our education department to share more widely in our agency? I'm not really sure what the rules are. I was the participant in the conference, and I'm providing my partner and I are providing education at the facility, but not, it's just a snapshot of what we experienced. So not to the depth that this provided.
Haley, I'm going to toss that to you.
Yeah, we do allow the recordings to be shared as long as you credit the program and make sure that it's very clear, the credentials of the speaker. But each of the webinars are recorded and those resources are provided to you. And then just for both our EOA and ICC participants that are on this webinar, at the beginning of both of your syllabus, you do have an accreditation statement that you can, when in doubt, just use that and that will provide the information. But this is here for you to use and to spread the wonderful information and resources that Judy provided. And thank you again, Judy. I've sat on this lecture many times and I always learn something new.
Thank you. Maggie,
Yeah, I was wondering if you had any experience or comment about the use of psilocybins.
I have no experience whatsoever. There's, obviously anecdotal stories coming out in the literature with wonderful little, stories about both patients and healthcare providers in palliative care who have used these agents, and how many find it just life-changing.
Yeah.
Others, not so much. Yeah. It's pretty labor intensive to do it well.
Yes, yes.
Thank you for asking that, Maggie.
If I may ask a question, this might be beyond the scope of this lecture, but sometimes we have patients, of course, who present with a current substance use disorder and a cancer diagnosis and cancer-related pain. Can you speak about how you treat those patients?
So Sarah, thank you. That is probably about a third of my population of patients. And in fact, I've just been developing a picture to kind of illustrate that it's not a homogeneous group. There are the people with substance use disorder who are in recovery. And in fact, I end up having to beg them to take the pain medicine. And even amongst that group, there are the people on methadone and the people on buprenorphine or Suboxone. And those are challenging in different ways, right? The methadone folks tend to be people who have fewer financial resources. So they have to go to a methadone clinic. Some of our clinics are great. And some of our clinics, and this is speaking of Chicago, so I can't really speak to the US in general, but I've had some clinics kick out patients when they have a cancer diagnosis because they don't have the resources to help. But I've had others who have been wonderful. When I've called, I've told them the person has, a serious cancer, and they say, well, let's pull together more resources for him or her. So those are those groups. I find those groups to be a little bit easier to work with, even though there's some pharmacologic challenges with buprenorphine or Suboxone. The other group is the group of individuals who are like, I don't have addiction. I don't have any problems with substance. I totally reject that I have substance use disorder. I have a couple really challenging folks like that right now. And I think you use some careful, safe prescribing. As Mary talked about, you can do a day prescribing. I can't do that in the outpatient clinic, but I do a week, and I wean. I optimize my non-opioids. I optimize any interventional techniques that could be done, blocks, anything that might help a particular kind of pain, radiotherapy, if it's a bony metastases, for example. We do everything we can to try everything to keep the opioid dose as low as possible. And we don't add a lot of other mind-altering kind of drugs. I am finding, and this is really disturbing to me, I've got a lot of people who they've reduced the opioid dose. So what are we doing? Oh, we add lots of Flexeril, cyclobenzaprine, or we're adding more Fioricet, or we're adding cough medicine. I have a patient who seems to have a cough like every 2 weeks with codeine, though. It's got to have codeine in it. And she's getting that from her primary care doctor. So that's where looking at the PDMP helps me to say, there are other ways to manage cough besides with opioids, right? So Sarah, that's a really, really challenging question. I will say there was a lovely article that appeared in Betty's journal, the Journal of Hospice and Palliative Nursing, just came online about maybe a month or so ago. It's by Sarah Lowry, Lowry, and it's a great case report with a very nice review of the literature about how do we manage pain with opioids in people with a serious illness. It's called When Management of Cancer-Related Pain is Complicated by Coexisting Opioid Use Disorder. And I found it to be extremely well written, very real world. So again, the author is Sarah Lowry, Lowry. Haley, I don't know if we can send a link.
I can, I just made a note. I'm gonna upload the PDF of the article to the Dropbox folder for both ICC and EOA. I think Sarah actually might be on this call, but she is a veteran of EOA and ICC. So that's really great, but I'll make sure to upload that to the shared Dropbox and include it on our next email for both cohorts.
Super.
What do you feel is the role of marijuana, medical or otherwise, with in this whole equation?
So we'll just say cannabis in general, right? Because many of my patients get the card and they can't afford it through the dispensary, so they get it off the street. It's pretty much similar. I know many people, this is really a whole nother hour-long discussion, but some of the pitfalls patients, think that because it's medical, it's somehow better, and it's really not. It's the same, essentially. I always ask patients, what are your goals? And if they tell me my goal is to reduce my pain, or my goal is to treat my sleep, or treat anxiety, or treat appetite, we can try it. But if they also tell me my goal is to maintain all of my clarity, then we really question whether cannabis may be the right choice. So it's a lot of questions that I ask, both again about their past use of cannabis. Baby boomers have often tried it, but now they're in their 70s. I've just had 2 patients end up in the emergency room because family members really strongly encouraged older adults to try cannabis. And even though they were edible gummies, they both ended up with altered mental status. So it's not an easy question. So Mary, I'm going to say thanks for raising that as our final point. I will just finally say that the International Association for the Study of Pain, very scientific organization, conducted numerous systematic reviews just within the last year, both for cancer pain, for chronic low back pain, in animals, in humans, and they cannot make a recommendation because the data are too weak. So we need a lot more science. All right. So Haley, I think we are at the final hour, final minute.
Yes, thank you so much, Judy. So informative and always so helpful. I know that on behalf of everyone, we always enjoy your presentations. As I said before, I personally always learn so much, so it's always been helpful. And if anyone has any questions after the presentation, please feel free to email myself or Elnick, and I'll make sure that Judy gets those questions and those answers to you. And then right now I'm uploading that article that we were talking about a few minutes ago, so you will be able to access that. But thank you so much, Judy.
Thank you. Thanks to everybody. Appreciate you being here.